Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing health care to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Early Stage Breast Cancer, What You Should Know, presented by Dr. William Wood, surgeon with Washington Township Medical Foundation and Section Chief, Department of Surgery at Washington Hospital. Before we begin our presentation with Dr. Wood, I would like to introduce Tina Fernandez-Steckler, Executive Director of the HERS Breast Cancer Foundation. HERS has been serving breast cancer patients in the Bay Area for 25 years. Tina is here today to tell us more about HERS and the services they provide. Please welcome Tina Fernandez-Steckler.
Thank you for that introduction, and thank you for the opportunity to share about HERS Breast Cancer Foundation today. As the introduction stated, HERS is now in its 25th year of community service, and it is an honor and a pleasure to serve Bay Area breast cancer patients. HERS was founded in 1998 by 3 dynamic women, one of whom was a breast care patient herself. They were determined to meet the unique needs of breast cancer patients following surgery. HERS was originally known as Bras for Body and Soul, but over time, and with the change in programs and services, our name changed to what it is today, HERS Breast Cancer Foundation. HERS is actually an acronym for Hope, Empowerment, Renewal, and Support, which are the feelings and the things we strive to restore in each of our patients. Our tagline is a soft place to fall, and that was coined by one of our dear patients who shared with us that during one of the hardest times in her life, HERS was her soft place to fall. Our mission is to support all individuals healing from breast cancer by providing post-surgical products and services, regardless of financial or insurance status. We actually serve patients from all walks of life, but for patients who are underserved, including individuals who are low income, underinsured, or uninsured, our assistance programs ensure that they have access to post-surgical products that help them heal, both physically and emotionally. Our mission, our assistance programs include We Support, You Survive, our Lymphedema Project, and Hair with Care. As you can see here on the screen, these are actual photos of patients being served. Our We Support, You Survive program for underserved patients provides post-surgical camisoles that provide support, breast prosthetics or breast forms if they have had a breast removed or even a partial breast removed due to surgery, and pocketed bras. Our Lymphedema Project provides underserved patients with compression sleeves, gloves, and gauntlets if they have active lymphedema, which is a condition caused when lymph fluid backs up in the limbs. Hair with Care is our wig program for patients experiencing hair loss. Our team of professionally trained staff members ensure that our patients receive the highest level of care. We have a very diverse team. Our staff currently speaks about 7 different languages, and we ensure that we meet our patients' needs no matter what stage of the journey they're on, and we make sure that we address our patients in a manner that's culturally competent. We have 3 locations in the Bay Area. We have a partnership with Fremont, Washington Hospital Healthcare System in Fremont. Our Washington Hospital location at Washington West is our longest running and our largest location. It's a beautifully appointed program location, and we offer all of our services at this location. We have 2 smaller satellite locations, one in Livermore at Common Point Nonprofit Center, and one in San Leandro, which is a partnership with Kaiser Permanente. We sustain our programs through fundraising all year round, through grants and donations. We also host 2 major annual fundraisers, our Spring Gala and our Fall Walk Run. We also complete all year round substantial community outreach so that we can reach patients and let our community members know about the products and the services that we offer. We would be happy to connect with you if you have any questions about our programs or services. If you or someone you know might need services, we are here to help. Our website is www.hersbreastcancerfoundation.org. We can also be reached at the number on your screen, 510-790-1911. We are happy to connect with you, and we are here for you. Thank you so much for the opportunity to share our mission and information about HERS.
Thank you, Tina. And now I would like to introduce Dr. William Wood. Dr. Wood is a general surgeon originally from San Francisco. Dr. Wood received his undergraduate education from University of California, Berkeley. After completing 2 master's programs, one in Michigan, he earned his medical degree and completed his internship and residency at the University of California, San Francisco. Experienced in a wide variety of surgical procedures, Dr. Wood is comfortable performing laparoscopic or open procedures, giving him the flexibility to adapt treatment to best meet the needs of the patient. And now, please welcome Dr. Wood.
Thank you for the warm introduction. I'm glad to be here. It's a pleasure to speak with you today, as this is one of my dearest topics and privilege to take care of patients with these diseases. So thank you. So I don't have any disclosures for today's discussion. First thing I'd like to cover is epidemiology. This means the study of disease at a population level. And breast cancer is the most common cancer amongst women. However, lung cancer is the number 1 cancer for men and women, as well as the most deadly cancer. The average lifetime risk for developing breast cancer for women is around 7%. That's 1 in 14. We do know established risk factors for breast cancer, including female sex. As age increases, the increased prevalence of breast cancer increases. Obesity greater than 30 of BMI is also a risk factor, as well as certain races and ethnicities. Estrogen exposure is a primary cause for a risk factor for breast cancer, and that includes age of onset of menses, as well as use of oral contraceptive pills, as well as how many times a patient has been pregnant and delivered babies. When discussing breast cancer, it's really important to discuss invasive versus non-invasive types of breast cancer. Invasive simply means the ability for a cancer to spread outside of the local area, so in this case, cancer outside of the breast. Common examples of non-invasive breast cancers include LCIS and DCIS, commonly known as ductal carcinoma in situ and lobular carcinoma in situ. Early breast cancer simply means that the cancer has not shown any evidence of spread outside of the breast or outside of the tissue. Now, when discussing breast cancer and the diagnostic approach, really what you need to do is think about the patient first. Are there changes in appearance or feeling of the breast? Are there any symptoms such as pain, itching, or changes in the skin with color, texture, or rashes? And then do you feel a lump, a new mass, a nodule? Has something changed in the nipple appearance? Or is there even any discharge, particularly bloody nipple discharge on one breast? The next approach for diagnosing breast cancer is imaging. Imaging comes in different forms. The first is ultrasound, which are targeted sound waves. Mammography, which is the common and most commonly used form of diagnostic imaging. This is ionizing radiation. Think of it as like an X-ray. And then MRI, which is a magnet that will polarize water molecules inside the body. All of these collectively display the tissues of the breast so that masses can be described and found, as well as the anatomy. You can also compare previous imaging to the most current for surveillance. The next stage in diagnosing breast cancer is to perform a biopsy. Something on or inside the breast was suspicious, both on physical exam as well as imaging, and it was recommended for a biopsy. This can be in the form of biopsying of the skin, a duct may be biopsied, a small needle can be used for aspiration biopsies, and then a larger needle for core needle biopsies are most commonly performed. An excisional biopsy is usually reserved if the previous options are not available or inconclusive for diagnostic appearances. Diagnosing breast cancer is where the biopsy specimen is reviewed by a pathologist in the pathology lab. It's important for the tissue to be analyzed with special stains, as well as for checking for hormone receptors. These hormone receptors are used for appropriate staging, as well as treatment, planning, and purposes. When discussing care and treatment of breast cancer patients, the first thing that is done is a comprehensive tumor board. This is where all of the represented specialists are involved with discussing a patient's care, and so a formulated plan specific for that patient is done. The role players in these meetings will include the primary care providers, cancer surgeons, reconstructive plastic surgeons, radiologists, pathologists. Oftentimes radiation oncology is needed and oncologists are needed for that. There are genetic counselors who perform counseling and testing. A medical oncologist is also involved. Nursing navigators are important. We participate in cancer registry programs, so we have coordinators for that. As previously mentioned, we do have a lymphedema clinic, as well as an infusion center. Collectively, all of the represented specialties from each of these departments are involved at the Cancer Tumor Board, so that comprehensive care can be involved, discussed, and given for each individualized patient. Now, I'm a surgeon, so I perform operations for part of the care. Two different types of operations are collectively thought of, and the approach is a bit different. Breast conserving surgery versus mastectomy is what I'll discuss. Breast conserving surgery you can think of also as called a lumpectomy. Only a portion of the breast is removed, and that portion will be the part that has the cancer. A mastectomy, however, removes the entire breast. Reconstruction is often offered and given for every patient who performs a mastectomy. This can be done immediately or is sometimes delayed after the primary operation. For invasive cancer, a sentinel lymph node biopsy is often done. This is important because these cancers have potential for spread, and biopsying the lymph nodes is important for staging and ultimately for treatment purposes. After an operation and healing is completed, adjuvant therapies are offered. These are treatments after an operation. This may include external beam radiation, which is often done in conjunction with lumpectomies. Think of a lumpectomy and external beam radiation going together, one being your left hand, the other being your right. They go together. Chemotherapy and immunotherapies are sometimes recommended and given as well, but this is particularly useful in more advanced disease, and prognosis has changed, and so therefore therapy has changed. Patients often are prescribed suppressive therapies. This includes estrogen-reducing medicines, and these are often given for 5 to 10 years. This concludes the portion of my lecture. Let's go through a real-life example. Here we have a 45-year-old woman who presents to clinic. She had her first period at age 12. She's had one pregnancy at age 35 and delivery without any complications. She didn't have breastfeeding, and she did take oral contraceptives in the past. She has no abnormalities or symptoms of her breasts. She has a maternal grandmother with breast cancer at age 65, and her previous mammogram was 2 years ago. She visited with her PCP for her annual wellness exam and was recommended a bilateral screening mammogram. This was done successfully, and there was an area of concern in one of the breasts. Recommendations were given for further tests. This included a diagnostic mammogram, which was showing a spiculated mass with concerning features. A biopsy was recommended and ultimately was done. This was performed with core needle technique, and this was done at our Women's Center. The pathology was found to be invasive ductal carcinoma grade 2. The estrogen and progesterone receptors were both positive, however, the HER2 new receptor was negative. The patient was given her diagnosis and referred to a cancer surgeon and an oncologist for further coordination of her care and treatment. Operative planning was performed, and the majority of patients are recommended for and prefer breast-conserving surgery, lumpectomies. Because it was an invasive disease, which again has potential for spreading, a sentinel lymph node biopsy was done at the same operation. These operations are done at the same time, and patients will go home the same day. I'd like to discuss genetic counseling and testing because this patient qualified for these. For patients who are 50 years of age and younger, genetic counseling and testing is recommended. Any patient with triple negative receptors found, all male breast cancer patients, and any patients with Ashkenazi Jewish ancestry, as well as significant family history, are all recommended for genetic counseling and testing. Routine genetic testing and counseling is not done at this time. However, these are indications for tests to establish if you have a genetic indication for cancer. Our care is often given in our Women's Center. This is the homepage of the website, and it's a place where both imaging, navigating, and upstairs the Oncology Infusion Center are closely connected. Down the hall from this is the HERS Center that you heard from previously. We are associated and affiliated with UCSF through our Washington Cancer Center. And for location-wise, this is our map. For reference, at the top of the screen, you can see the BART station of the Fremont BART. And the Washington West building is where the Women's Center, HERS, as well as oncology and infusion centers are located. Adjacent to this is the radiation oncology building, where treatments are often done for those who need. And then across the street is Washington Hospital, where we perform many of our operations. My office and those of other cancer surgeons are located at the Star, just a block away. So this makes patients' coordination of care and access much more easy than having to find individual providers in the community or elsewhere, as we are all located centrally here for access and convenience. I'd like to mention some of our recognitions. We are an accredited program for breast centers through the quality program of the American College of Surgeons, NAPBC. We're also recognized as a center of excellence by the American College of Radiology, and that's an ongoing established recognition from 2012. Here are some of the folks who work in the Women's Center who are proud to serve and to perform mammograms. And this is one of the machines that's used. It's an upgraded machine for tomosynthesis, also known as 3D mammography. Lastly, I'll mention that we have an upcoming event on May 18th, Thursday at 6 to 8 p.m. This is a celebration of life, and it's an 14th annual celebration, and you are all invited. Should you need to contact me, my office information is here, and I'll be glad to see you. Again, and thank you for your time. It's a pleasure to take care of all patients, and it's a personal enrichment and part of my practice that I enjoy doing. Thank you again.
We do have some questions. How likely is it for a patient to have a clear mammogram one year and the next year have stage 2 or higher diagnosis?
It's not very likely. However, it's possible that and more advanced disease may have progressed in over a year's period of time. Not very likely, however, and that raises the importance of an annual mammogram for screening. And the recommendation through our system is for an annual mammogram. And catching breast cancer early is important for early treatment and ultimately the care that is needed and deserved.
Thank you. And our next question is, how do I go about getting screened for breast cancer?
The easiest way to obtain screening for breast cancer is a visit with your primary provider. Those persons can easily order a screening mammogram, which can be done in many different places. And the recommendation is for a 3D tomosynthesis mammogram. This gives greater detail of the anatomy of the breast and can establish earlier, smaller appearing abnormalities on a mammogram.
Okay, and then our last question. At what age should a woman start her screening for breast cancer?
This is a little controversial because there are different organizations, task force, and groups that have different numbers, specific numbers for recommendation. At Washington, we believe that screening should begin at age 40. And this is to detect earlier breast cancers and ultimately treatment at an earlier stage.
Okay. Thank you for your time today, and thank you for answering our audience questions. This does conclude our program. Thank you, Dr. Wood, for this insightful presentation, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.